Good morning, everybody. Can those of you that are online give a thumbs up if you can hear me? Woohoo! Okay. So I just asked Nathan if we have quorum. We currently do not. So I just wanted to make you all aware we are going to give it just a few more minutes to see if we can get a few more people in. So bear with us. Thanks for your patience. Perfect. Yeah. Nathan just wanted me to also remind everyone this meeting is being recorded, just as a FYI. Thank you so much. Okay, so I've just been informed. We are just waiting on 3 more members to arrive at quorum. So thank you guys for bearing with us. Give us just a few more minutes. Thank you so much. Okay, well, we are still waiting for a few more people, but we are going to go ahead and just move forward a little bit in our agenda to the roundtable updates so that we don't have folks waiting forever. So I guess let's go ahead and start with the folks online. Nathan, I can't see who's there.
Hello, hello. We'll go ahead and I'll call on people virtually to do the roundtable if you have anything to share. And then we'll go ahead and go around the room. Okay. Clarissa Fletcher, do you have anything to share?
And good morning, everyone. No, I really don't have any updates.
Robert Hopkins.
Good morning. Just looking forward to the HCA-sponsored co-occurring disorder treatment conference in October 16th and 17th, or 15th if you need the ethics class as well. There's several scholarships that are still available, so if you or any of your people are interested in that, please check it out. It's my only update.
Robert, would you go ahead and put information about that in the chat? Thank you so much.
I will send a link. Thank you.
Miranda, and could you do a brief introduction? Miranda is our soon-to-be new Commerce Housing required seat in terms of state represented members.
Hi, everyone. I'm Miranda Meyer. I am the new Behavioral Health Liaison at Commerce, and thank you for having me. And I have nothing to share at this time.
Katie, do you have anything to share?
Good morning, Katie from the Division of Vocational Rehab. And no, I do not have anything to share. Thank you.
Stu Parker?
Good morning, everybody. Stu Parker, vendor with NetSmart Technology. I'm Director of Public Sector, and nothing to share, just a guest listening in and hearing what's going on in the state. Thank you for having me.
Jolie?
Good morning. I'm Jolie Ramsey from the Washington State Rehabilitation Council, which is a partnership of the Division of Vocational Rehab. Not much as far as updates that pertain to the work of behavioral health at this time. We're gearing up for our quarterly listening sessions with DVR customers. But that's about it. Thank you.
Right, and then finally we have Brian. I know you're presenting. Do you have anything to share before your presentation?
I do not, but I'm Brian Rebar. I'm with Carillon Behavioral Health, and I'm the convener of the Behavioral Health Advisory Board for North Central Washington. And I'll be sharing a little bit more about that in a few minutes here.
Okay, we're ready for those in the room.
I guess I'll start since I'm on the end of the table. Good morning, everybody. My name is Rochelle Madigan. I am one of the co-chairs for Behavioral Health Advisory Council. My cohort, Josh Wallace, is not here today because he's attending a national conference. Lucky guy. So I wanted to take just a moment and say, I chatted with Nathan before the meeting, and those of you that are not in the room, we have these lovely little name placards. So when you come in person, you'll get your very own lovely name placard. But I chatted with Nathan because I think it's important, besides acknowledging our name and what we do, these have our name on it. Mine says Rochelle Madigan, statewide family advocate. So it says my name and something about me. But I think it's also really important that we acknowledge that every time we enter a space with other people, we come with our lenses. And we're in this unique and beautiful place in time where decision-making tables are being infused with voices of lived experience that don't necessarily have professionalism or titles behind their name, but their perspectives are helpful and needed to make meaningful changes. And there are some inherent growing pains that come with that. And I think that the solution to those growing pains is understanding and acknowledging our shared humanity at the start of every conversation. So I just want to say, authentically, I have been going through a separation with my husband, and I've had a rough couple of weeks. This morning, we actually had some really meaningful conversation. And so right now I'm feeling hopeful, but I haven't been eating or sleeping well for about the last 2 weeks. So I'm coming into this with that as part of my lens, and I just want to be authentic about that. And I asked Nathan, for these little name placards, could we going forward have like a Velcro or a magnet thing on the bottom so that we can all write what lens are we coming in with today? And maybe that will lead us to a place of, more understanding with one another as we have discussions that can help move things forward for families in our state. With that, I have been working on something. I do a lot of volunteer advocacy work. I also recently, in May, I took a job with Washington State Community Connectors. And in that role, I have been working on a lot of things, but one of the things I'm really excited about is I'm trying to put together an event that will network community and family-run organizations and bring them together at least once a year. We're in the baby steps of that planning process, and that requires that I have a list of all the community orgs and family-run organizations, and right now nobody has that list. So I have an ask of all of you, if you would be so kind as to send me the ones that you know of from your neck of the woods, any family-run organizations, not necessarily like service provision organizations. I'm thinking more of the things that aren't formal supports, but that people use as behavioral health supports where they live, where the rubber meets the road. Things like Spark and FlyStart that Vanessa is a part of, and so many others. So anyway, my email, my work email is, Nathan, can you put this in the chat as well? It's Rochelle Madigan at wsccsupport.org. So if you guys would be so kind as to send me lists of your organizations that you're aware of, I would be so thankful. That's all I have. Thanks, guys.
Good morning, everybody. I really hate talking into these things. Um, my name is Carolyn Cox. I am the Executive Director of the Spark Peer Learning Center in Eastern Washington. We are out of Kennewick, Washington, but we have hubs all over the state. One of the places that we're working quite a bit with right now is North Central Washington. So we're really excited about really building our presence up in Moses Lake area, Wenatchee, Okanagan. So super excited about that. I'm also, or our organization is also a training entity for the certified peer counseling classes. We are the only one right now doing the family and youth trainings in person. En route does them online, but Spark does them in person. Let's see what's going on with Spark. Wow. So as I said, we're a training entity for the certified peer counseling classes. We also are doing the crisis awareness trainings, which we have one starting next Monday, which is super exciting. And in Kennewick. And then I know that there's one going on here on the west side, the same dates, so the 11th through the 15th. And they're full. We have a few spots open, but they're going fast. I'm really excited about this training. And let's see, Spark is also working with WISE programs across the state to help with the workforce development for WISE, especially getting youth and young adults into peer counselors. That's one of our main tasks with one of our contracts. And we so love and enjoy working with youth and young adults. We're actually going to be talking about hopefully working with the prenatal folks at HCA to do some trainings for first-time parents and teen parents. So really excited about upcoming things, and I'll leave my information in the chat as well. And so good to see you on here, Brian.
All righty. My name is Gabriel Hamilton. I am the youth peer specialist at Spark Peer Learning Center, so I get to work with Carolyn. I've been a youth or a peer for 5 years now, so almost, or 4.5 years, almost working with Carolyn for a year, if not a year now. So yeah, it's been a year. Okay, cool. So 5 years, I've been a peer. I was a youth peer for 4 of those years. I am a statewide tri-lead at the Family Youth System Partner Roundtable. I'm the youth tri-lead, where we're currently trying to build out, or I'm trying to help assist in building a youth network or youth group area so that these peers can come and talk before the FISBRTs or the statewide FISBRT, and we can address some of the issues that are going on currently. And then, like Ms. Carolyn said, we have a lot of work going on. We also did a peer pathways panel, and out of that, we got a lot of data that we're probably going to be working towards with a couple of other agencies, and probably working together to figure out how we distribute that, but that data on how we get those main issues met that were brought to us at that panel. So yeah, I think that's everything. And then I'm coming today from a very tired lens, but my wife and my son are hanging out with their Nana today, so I'm a happy lens as well.
Good morning. My name is Vanessa Lewis, and I'm with the PAVE organization, Partnerships for Action, Voices for Empowerment, and we are the parent training program for the state of Washington. And there are other programs underneath the PAVE umbrella as well. I'm a parent resource coordinator, and actually, as of July 15th, I've been at PAVE for 26 years. I can't believe it. So, I know they want me to sit down, but I can't. But anyways, cannot retire yet. But anyways, the work that we're doing continues with training and education for families and professionals who are navigating the special education system. We also, actually, school has started, so our work probably started early this summer, preparing for meetings, helping families navigate the systems, and then also doing trainings. Right now, with ESD 114. So we have been doing trainings in person, but this quarter, this year, it'll be virtually to support the families that can come in the evenings. And so anyone outside of Kitsap County is welcome to attend them as well too. So, and then as far as the lens that I'm coming from, I'm happy and I'm grateful, to be alive, and also that I made it here, and there's nobody here but us in person. But it's all good. It's all good. Thankful for technology as well too.
Good morning. My name is Tessa Clements. Starting off with my lens, I had a Memorial Day softball tournament this weekend, so this is not my normal voice. I am too old for softball, but you do what you got to do. I'm the Behavioral Health Program Supervisor for the Administrative Office of the Courts. Some of the things we've been working on recently, coming up in 2 weeks is our judicial conference. Every judge in the state has access to this conference, and our team is sponsoring a judicial and psychiatric leadership session. It's a plenary session that it will take up half the day with Judge Maurer from Spokane and Dr. Matt Layton, who we have sent to Washington, D.C. to work with our national partners to have a really interesting presentation on what it's like to enter a courtroom with psychiatric issues, and to help judges how to understand how that feels and how to best address it, which is kind of the crux of the work that we do. We've also been engaged in some assisted outpatient trainings and conversations as of lately, and we have recently added a new member with trauma-informed criminal justice training who will be organizing those as well as recently providing a traumatic brain injury training to judges and court managers to understand what it looks like when somebody with traumatic brain injury enters your courtroom and the extra help they might need. And then this Friday we'll be hosting a risk needs responsivity training, so courts can understand why those assessments are important and why we should be focusing on needs and responsivity to help people be successful coming out of the courtroom. Which one specifically? Oh, that is the judicial conference, so it is specifically for our judges. Even I had to get a special invite.
Hello, everyone. My name is Tori McDermott Hale. I'm the DBHR Block Grants Data Report Specialist.
Good morning, everyone. I'm Janet Cornell. I'm the Federal Block Grants Manager. My lens this morning, it's first day of school, so we got to do the morning rush of new schedules and all that good stuff. So I'm feeling a little frazzled and need more coffee. Updates for the block grant. The block grant application was due last Friday, September 1st. We got it submitted Wednesday, the 30th. Yay. So that was awesome. Really want to extend our thanks again. I know we're going to talk later about it, but really, really appreciated all of the feedback and effort that went into the review this year. It was really meaningful and helpful, and just really appreciate the collaboration that went into that. Coming up for the block grants, we get to dive into the progress report that's due December 1st. And so that's a pretty big lift. We get to start working on this month to work on reporting out on all those priorities that we work on for each year, talking about how we did with those, if we met the goals, getting all the data, providing some narrative feedback on all of that. So that's the exciting stuff going on with block grants. Okay, we still do not have quorum, so we will not be able to approve our minutes or do our voting of the new members at this time. If at any point during this meeting we do achieve quorum, we will let you know, and we may still do those things. But for now, we'll go ahead and move forward. Looks like the next thing on our agenda is the presentation from Brian Rebar. Brian, are you all ready to go?
Yeah, absolutely. I can get going with that.
Turn it over to you then.
Great, great. Well, as I mentioned before, I'm Brian Rebar. am with the North Central Washington Behavioral Health Advisory Board, I work for Carillon Behavioral Health, who is the Behavioral Health Administrative Services organization for 3 regions in Washington, one of which being North Central, and the other being Southwest and Pierce County. I'm the community engagement coordinator, which means that I convene the BHAB. I also convene the Family Youth System Partner Roundtable for North Central. I convene the community partner committees for the Children's Long-Term Inpatient. And the bulk of my role is managing the federal block grant funds for substance abuse and mental health programming in North Central. And today I'm here to share about the Behavioral Health Advisory Board for North Central, sort of what we, with our public comment, and let me go ahead and share my screen here. I think I should be able to do that. But I'm going to be giving an overview of the public comment that we've received, what we've kind of done with it, and what our plans are kind of moving forward here. So let me, okay, can you all see this fine? Okay. So for the Behavioral Health Advisory Board for North Central, in June of last year, we had a retreat, sort of a retreat as a board to talk about, kind of reassess, reevaluate what our mission is as a board, what we do with public comment, how we receive it, what we do with it, and just kind of general restructuring. This is our new mission statement: to identify and break down barriers related to access to behavioral health care and meet with stakeholders to advise on trends, quality of care, and other related service issues in the North Central region. At that retreat, we kind of reassessed what that mission statement looks like. And the bulk of the work we've done in kind of restructuring and reframing what we do is within the public comment, specifically in our role as an advisory board. What we advise on, how we advise, what our role is in taking action after we receive that public comment and see what it means. And so what that's kind of looked like for us is we have each month we have a targeted ask or request out to the community. And it can be based on whoever that, whatever the topic schedule is, or whoever is presenting on what sort of topic, and we kind of frame the public comment around that to go nicely. Or, we may have a one-off thing that's based off of something that's going on in the region that we want to highlight. And it may not line up with the topic, but it's something that is something that's been coming up recently in the region. We have a form of kind of tracking and analyzing that public comment, looking at trends, identifying those trends, seeing what's kind of going on in the region, what behavioral health issues, related to gaps or barriers to access to care for people within the behavioral health system of care. And looking at the different action steps we can take, have been taken, who can be charged with taking those action steps. And we report kind of the bookend of that cycle, that kind of resets each year, is reporting that public comment out to kind of key leaders in the behavioral health system who can kind of make an impact at different levels, different levels of the system. And this presentation was presented to those group of key leaders with an ask, and this, obviously me presenting this here isn't so much, part of it is kind of seeing what kind of collaboration can be done between the Behavioral Health Advisory Council and the Behavioral Health Advisory Board in North Central. And we're actually hoping to have, I think Michelle is likely going to be, we're in talks about her potentially coming out to the BHAB to present on the BHAC and have some discussion about what collaboration might look like between the BHAC and the BHAB. So this is kind of an overview of, a breakdown month to month I'm not going to go through this with a fine-tooth comb or anything. I already sent this presentation ahead of time, and so you all will have it. If you have any questions or follow-up, want to talk to me about any of these trends that we're seeing here in our region, or recommendations, or thoughts or comments, please do reach out to me, and I can throw my email in the chat as well. But as far as the month-to-month breakdown, the first 2 months, May and June, we were kind of getting learning the ropes or sorting out our public comment. Those were kind of general months. Ended up having a trend come out of need for some specialized training with Indigenous peoples, that was a gap there. And then in June, there was some questions circulating around social media that was brought forward in public comment about our Oxford housing, and that it's a lack of female-centric housing services, or specific for females in the region. To the right here, we see some action steps. We followed up with Oxford Housing leadership, and that Kelly Rimby came and presented on that the following month. In July, and I'm going to talk about this as a dedicated slide for veterans behavioral health, because this has been a big focus in the region for a lot of different reasons. And I've done a lot of follow-up work related to this kind of issue we identified in our region. And there'll be a slide about that later. In August, we lost our powerhouse. It was called the Powerhouse, but it was a kind of a homeless services organization. We lost that, so we talked about housing, different strategies, ways we can address that. Asking the public, was this resource useful? Are there other agencies what are other agencies doing to kind of pick up the slack and help with the offset of services for that? And then in September and October, we kind of emphasized behavioral health in the emergency department. So there's a program that has been going on, that's been in development in North Central, with Thriving Together, formerly our Accountable Community of Health, the North Central Accountable Community of Health, talking about installing kind of a mental health triage team in the emergency departments. Because a lot of the time, when somebody with a behavioral health concern or someone in crisis, goes to the hospitals, a lot of times staff aren't properly trained to help that person. And it can make for a difficult experience, and maybe not the smoothest experience. We received a lot of public comment expressing the desire and need for something like this. And that has been a partnership between Dr. Julie Rickard with the Suicide Prevention Coalition and Thriving Together to start up this programming. There's already been a lot of coordination going on with the hospitals, and that's been wonderful. And then in November, we talked about trauma-informed care, kind of a continuation of the previous conversation, but honing in more on the specifics of, getting to the crux of the issue, why this is difficult, why specialized training for staff or specially trained staff within the medical system is important for behavioral health issues. For behavioral health individuals. And in January, we talked about the Recovery Navigator programs in North Central, and we got a lot of positive feedback and a lot of encouragement for an increase in these services and support for this programming. In February, we focused on the block grant providers in our region and talked about, potential areas of improvement, highlighting different ways that they thrive. And one of the big, and I'll talk about this a little bit more on a later slide, but one of the big things for behavioral health services in North Central is there's a real lack of detox services. The Center for Alcohol and Drug Treatment had our detox programming previously, but the reimbursement rate for detox services is not very feasible, wasn't very feasible, and they had to close down the program. And now our region lacks detox services. And that was a big identified issue through that. In March, we talked about syringe services. There's a syringe service program, or safe syringe program, it's known by several names, but it's in development in North Central, between a partnership between Carillon Behavioral Health, my organization, and Thriving Together to support the YWCA in Wenatchee, the Wenatchee area to host this programming. And that's been in development. That has been a big thing that's come out of the Behavioral Health Advisory Board, and out of this month in March specifically, as many people spoke up about this being a big need. And that has been something that's been in development there, which has been wonderful, and hoping to get that off the ground very soon. Also, during this share out of the public comment, we've done a lot of partnering with the Office of Behavioral Health Advocacy, and our behavioral health advocate in North Central is Nani Nicolette, and she attended and shared the public comment they have received through their behavioral health forum, which they have every month. And the BHAB, we did a lot of collaboration with the BHAB and the behavioral health forum, to try to minimize, any redundancy and make sure that we're supporting each other and, not taking away from the public comment we each receive, but trying to emphasize the work that both groups are doing, which has been great. And Nanine's been a great partner for that. But this is kind of an outline of a lot of what they've identified through their behavioral health forum, and obviously not an expert on this public comment received, but we can kind of review it real quick. So the first 2 months were general, and they, a lot of the times you'll see like a trend, because if the BHAB is requesting some public comment, a lot of times the behavioral health forum will also add that on to what they're asking for their month, which has been great, and vice versa. And that first month, a lot of different topics were covered: digital disparity, isolation. North Central is a very rural region, and so access to care and access to care being so spread out has been difficult, and a lot of difficulties utilizing technology. A lot of internet access is difficult in rural regions, and so that was a big point of emphasis there. And in March, again, with that detox services, that was a big emphasis there. Just kind of highlighting a few main points here. In April, they talked about behavioral health stigma, trying to see how we address that issue, because a lot of people, and specifically in certain cultures, it seems like the general culture, at least in the United States, has improved quite a bit, as far as, awareness about the need for taking care of your mental health and behavioral health issues is not as stigmatized as it used to be, but that stigma remains, even still. And it's also can be extra strong in different cultures. Some cultures are more open to behavioral health and taking your mental health seriously, and other cultures are less so. And I think a lot of the conversation during that month was surrounding, how do we make it so people, how do we respect the culture somebody has, but still helping people within that culture who feel like they can't reach out for help or feel like they'll be judged, and how do we reduce that stigma while still respecting someone's culture? That was a big part of the conversation. And then in May, we talked about social media, the effects of social media on youth mental health. This was a big topic. In the following month, in June, I mentioned I convened the Family Youth System Partner Roundtable, and I gave a presentation on the effects of social media on youth mental health. And it was largely influenced by the Surgeon General's advisory that was put out, which is a great read, and I'd recommend anybody to give it a look. But really, really eye-opening, a lot of statistics, a lot of studies, a lot of really helpful, useful information on how to address this from all angles, you know, as a parent, as a stakeholder in the behavioral health system, as a youth. So there's a lot of conversation in May and June surrounding that topic specifically, and how to address it, you know, how to have social media. There are obviously many, many benefits for social media, but a lot of times we overlook the dangers and how that can affect our mental health, because a lot of times social media, when maybe the purpose of it is to be connected, a lot of times it can cause the opposite and be very isolating, or kind of limit our interactions in a way that maybe doesn't help us develop as human beings in the way that we interact socially with others, and that social development. And in those relationships online look very different than they do in person. And it can make it difficult to interact with somebody in real life when you're just over a screen and you can click off anytime things get uncomfortable. And so that was a really, really great conversation. And excuse me. And in June, we talked about workforce issues and wait times. You know, as we all know, you know, workforce is a continuing issue in behavioral health. It's a continuing issue across a lot of different sectors and fields, but, you know, I'd say especially in behavioral health, and, you know, those wait times are caused largely by workforce shortages. And that was a big conversation. And a big part of that conversation was centered around, you know, people are paying the money. The funding for a lot of times the funding is there. A lot of times the competitive wage is there. It used to be in you know, social work and behavioral health work that it was pretty low wages. And I'm not saying they're like super high or anything now, but there's been a lot of efforts put towards like really hefty sign-on bonuses and competitive wages. And yet we still see this issue of people not wanting to join this field. There's been a lot of workforce development work done in North Central, which has been wonderful. We're doing a lot of partnerships with the colleges to put in behavioral health programming, and to creating those pathways so that, you know, those graduating from high school have those options, feel like they have those options and know what the pathways are to do that. There's also been a lot of development in certified peer counselor work, and those positions, lots of positions like that, opening up more openness within behavioral health agencies to hiring peers for peer work, which has been great. Okay, so I know I kind of tore through these. Like I said, sent out those slides ahead of time. If anybody has any questions or commentary or anything about that, we're gonna have some time after the presentation to talk. And also, if you want to email me, absolutely, would love to hear from you. So one of the large focuses that we had, I mentioned back in July of 2022. Veterans behavioral health was a focus at our BHAB and our public comment, and part of that was due to, you know, a terrible situation that happened at our Apple Blossom Festival, where Alex White, who's a veteran, was experiencing a lot of symptoms related to his PTSD, and got into an altercation between police and himself, and he was shot and passed away. And that was, you know, created a lot of conversation in the behavioral health system in North Central surrounding, you know, trying to sort out, you know, what exactly happened through the whole thing. And Laurel White, Alex's mother, has been an amazing partner. She came and presented at the BHAB, gave a full presentation about Alex, about their situation, from beginning to end, as far as his behavioral health journey, after, you know, through being a veteran, you know, and serving and coming back, and all the things that he went through. And she shared a lot about that as a way, and she, like I said, she's been a wonderful partner, and she didn't approach it, she could have approached it angrily and, very justified with, with all of the hurt and pain that she's obviously went through. But she came at it with a, mentality of collaboration and what can I do to help the system? What can we learn from this? How can we make it so things like this don't happen or, happen less often? And she shared all of the different ways that maybe the system might have fallen short in some ways, and the ways that they didn't feel supported, and that they, she identified all sorts of ways that the system could have helped better. One of the big things that could, one of the very small changes that could have made a big impact is that she, as Alex's mother, did not receive any educational material on PTSD, didn't receive any, printed material that she could have just been handed, because she was, given wait times, long wait times, kind of passed around agency to agency as far as needing services. And those wasn't given anything on how she could help support her son. She felt like she wasn't equipped or didn't have the tools necessary to help her son, didn't know how to help him. And just some material to read up on or to learn about or anything while they were waiting to be seen. She mentioned that would have been so helpful. A lot of the recommendations that she had, was extra training, for medical staff, for mental health providers, and for related to PTSD specifically for veteran care. A lot of the times, unfortunately, behavioral health clinicians will receive someone with symptoms, and they will treat them through the lens of those symptoms, maybe not through the lens of them being a veteran and where those symptoms come from. And she mentioned more training related to veteran care, specifically veterans care, would have been helpful. And, the sleep, he was not sleeping very much at all. And, as I'm sure a lot of you know, sleep is, so important. It affects everything in our lives. It affects our mental health, our physical health. A lot of the times, if you get back to a regular sleep routine, it makes everything else so much more manageable. But it really does affect everything. And so that was something that she noticed that was just making everything worse for her son, was him not being able to sleep due to his symptoms. She mentioned that any questionnaires that they filled out were completed and whatnot, but they never saw it again. They never heard of them being used for anything else or, informing their care. She mentioned a lot of training for front desk staff, because a lot of their interactions with front desk were pretty not very great interactions. And again, mentioning of that literature, or having literature posted or provided or set out in the waiting rooms, funding services to target preventing crises and help families, employing more mental health providers to reduce time to access services, right? So that workforce issue. And so these are a lot of her recommendations in how to better help somebody, a veteran, going through behavioral health challenges, who needs help now. And that help doesn't mean that they need to be seen right now, if that's not the reality, but there are ways to help somebody, even if they can't be seen right this moment. And so a lot of the follow-up work we've done, we connected Laurel with Confluence Health to share her story, and also connected her with Thriving Together to take steps to see what can be done. A lot of Thriving Together's work is surrounded around addressing, gaps in the system. And so we partner because our goal as a BHAB with our public comment is to identify those gaps in care, Thriving Together has been a great partner for the nature of the work that they do to then carry out some action steps with the gaps that we've identified through our public comment. And, I've met with Laurel and Thriving Together. I've attended these meetings to kind of discuss how we can address this, facilitating those discussions, talking about different ways to approach this issue and improving veterans' mental health care. One of the kind of concrete improvements that came out from this is as I was calling around trying to see who within the veteran care, system within that world, because we weren't super clear on who to chat with. A lot of contacts had changed, and there just hasn't been a whole lot of collaboration between Veterans Affairs and the behavioral health agencies, even though obviously there needs to be. And so I connected with the Washington Department of Veterans Affairs and the staff who oversee the North Central region, and they had recently been awarded grant funds for the Staff Sergeant Fox grant, and they were, after we all discussed and we chatted about this being an identified issue, they decided to, I don't know if it was already kind of earmarked for that or if, this conversation kind of reinforced it. Laurel had reached out to them individually and then connected me in with it about this specific thing with the Staff Sergeant Fox grant. But those funds are going to be specifically utilized for improving mental health programming for veterans, specifically in North Central, which is something that we don't have a lot of, if any, I don't think, mental health care specifically for veterans. And that funding will be utilized specifically to, and we've already identified an agency who's willing to take on that programming, to utilize those funds to start up that programming. And so that's wonderful. So that's something that's a big change that has come from this public comment we received, all the way back in July of 22. And I'm just thrilled about that. And I continue to be in that work group to, obviously that my role being that I manage the, behavioral health federal block grant funds. I've offered to be involved in this to both because of, I want to stay involved and help address this issue, but also to offer, some advising as far as grant funds. We pilot programs all the time with the grant funds. And so I'm offering my assistance with that for piloting this program. So throughout all of our public comment, these are really the main issues we've identified through our public comment. Needing more specialized behavioral health resources for veterans, as I mentioned. Improve behavioral health care in the EDs, right, in the emergency departments, and training staff and trauma-informed care. Not enough services for parents dealing with youth in crisis. One of the big topics of discussion that we had that came up out of sharing this information was the lack of youth services, lack of, and specifically lack of youth detox. I don't think, to my knowledge, there's any youth detox anywhere in the state, any detox programming specific to youth. And that was a big part of the discussion when we shared out this public comment to those key leaders in our region. And need for more harm reduction resources. We talked about, we piloted meaning Carillon, we piloted a Narcan vending machine program in the North Central region, and it's been very successful. And we add new machines all the time throughout the region, and we're talking about including more diverse harm reduction resources within those machines, and also just other ways to get harm reduction out there, but looking into putting them in those machines to kind of widen the support we're able to offer through them. And like I mentioned, inpatient and detox services for youth, and generally more youth services for youth in crisis. The rural isolation and technological limitations, that's, like I mentioned before, that's been a major issue in our region just to the rural nature of the area and how spread out everyone is, and difficulties in internet access and internet connectivity based off of the area they're in. And like I mentioned, there's been a lot of work dedicated to the workforce development in our region with those partnership with the colleges, creating those pathways. But that continues to be an area of focus because of that issue, which, obviously worsens everything else, right? The workforce just kind of makes everything else more difficult. So that's been a big focus. And more education, both destigmatizing behavioral health and also, kind of pointing out the potential issue of social media on youth mental health, kind of prompted by that Surgeon General's advisory. So a big part of the discussion, with the key leaders and maybe some things for you folks to be thinking about at a state level and how these issues can be, what kind of support could be offered to working on these issues. Are there any things that this is kind of a portion that maybe we can have a discussion? I don't have anything after this. This is as far as the presentation, is kind of the last slide. So kind of before we jump into any of these questions, do you guys have any questions for me as far as this presentation goes so far? Kind of threw a lot of information at you all, so I wanted to give a chance before we jump into this discussion here.
This is Rochelle. First of all, I just want to say I am a resident of the North Central region. I live in Moses Lake. And so as a person that resides in the North Central region, I just feel so proud about the information that you just shared, that I live in a region that's on the cutting edge and working hard to make connections where they need to be made. And I just really appreciate that, and want to acknowledge the work that you've put into bringing us to this place where you just gave that presentation, because I feel like that needs to be acknowledged and honored. With that, I feel bad for you because I'm going to be bugging you. You just said a whole bunch of things that I'm really excited about and
Sure.
Looking forward to partnering with you on in whatever way that I can. Yeah, I have all kinds of questions, but I'm going to probably be emailing you.
Okay, sounds great. Sounds great.
Anybody else have questions?
Yeah, anyone else before we kind of jump into this? Okay, well, so these questions, as I was kind of reviewing them, seeing like, okay, could these be shared with the BHAC? Are they specific to the region? I don't think so. I think there a lot of these, we could have a discussion based on these here. And I guess, were there any on these identified issues, and I'll jump back to this slide, were there any that stick out to you? Do you, in the sense of, is there any work being done to identify any of these issues at a state level that you could make me aware of? Are there any things you've seen that have been successful before that you would recommend us approaching? Is there any way you feel like in your role or as a BHAC that you could help to address any of these issues? And I'll keep these on screen here.
I'm not sure if we can help to address them, but when we were looking at recommendations for the new block grant, one of the things that came up was trauma-informed care training for all levels of staff in every behavioral health agency, because each and every one of the staff there has the likelihood of interacting with somebody that is in the midst of crisis. So I hear you on the front desk staff. In fact, when I was working feet on the ground, it was one of my biggest complaints was the front desk staff was not able to identify somebody who was experiencing trauma in the middle of a crisis, and they're the gatekeeper for the entire agency, whether that be on the phone or in person. So it's definitely a real issue that needs to be addressed. I don't have any idea how we can do that other than getting some crisis intervention training and trauma-informed care training to every level of staff at all behavioral health agencies.
Sure. Yeah. I think a lot of times these positions, because I've seen the job descriptions for a lot of these front desk positions for behavioral health agencies, and they're pretty general. A lot of behavioral health experience preferred type of thing, and I think you're right. It's so necessary, so needed for those staff at the front desk to not just be able to quote unquote handle these situations, but being able to genuinely serve somebody in the way that they need to be served. And because I've seen a lot of situations being escalated unintentionally where maybe someone, obviously there's nothing wrong with how they handled the situation, but because they didn't have that training, they weren't looking out for these different ways that they could be, different ways that might escalate a person, right, who is coming in with certain issues. And that training is so important. For a little side note here, did I read or see that this meeting is being recorded?
Yes.
Okay, cool. Just want to make sure, because I'm on vacation, have a laptop right now, and so I can't really take notes right now, and so that's helpful to know. I will be reaching out about that recording. Okay, so
Ryan, I wanted to just say really quick, I feel like the timing of this is kind of awesome because recently I can't remember if it was an executive team meeting or if it was a general meeting, but I mentioned to DBHR leadership that I felt like we were missing an opportunity by not being more connected with the regional behavioral health advisory boards. And so I feel like you coming here and giving this presentation is a really good springboard from which I have all kinds of ideas bouncing around in my head about how this needs to be a model where all the regions are gathering up their observed trends and bringing them to us, and that's getting funneled into our block grant recommendations. So obviously that's just me saying that's what I'm thinking in this moment. I don't run the show, so I will be discussing this further with the executive team and others, but I'm really excited about this conversation and what might come from it. So thank you for being here.
No, appreciate that. That's great to hear. I think when we had that retreat with our BHAB restructuring things, the BHAC came up as, a potential avenue for sharing our public comment, at the state level and so if you guys are open to it, I'd love to just kind of set this sort of thing into our structure for our public comment share outs annually. Obviously, please speak about that internally. No need to give an answer now, but if there's openness to that, excuse me, I think we'd love to do that, and I can take that back to the board to talk about that as well. Okay.
Hi, this is Susan. I just wanted to jump in really quick and jump on the comments about trauma-informed care. As it was mentioned, we did have a recommendation in our latest block grant recommendation letter to improve training for trauma-informed care, but I'm also pushing to go much bigger than that. I think with mental health and substance abuse, probably 80 to 90% of people have experienced trauma or PTSD. And so across the board, there's just not enough resources. I mean, I run into people quite a bit that, domestic violence victims, things like that, where there's just not much of anything out there. So it's kind of like we're addressing the symptoms of behavioral health issues versus the cause. So
Sure.
It's a big deal to me. So I'm just glad that you pointed out the PTSD issue because it's, to me, very big.
Yeah, absolutely. And, I'm from before I worked for Carillon, working in behavioral health at an administrative level, I worked as a clinician providing counseling therapy, and doing that work made me realize, that I have some trauma, and doing some some introspection for myself and realizing, I think you mentioning, 80 to 90% of people have trauma. I think a large percentage of those people don't realize that they do. Don't even realize that they have it, because I didn't realize I had it. We only know our own personal experience. And so we assume that our experience is similar to most people's, you know, and when in actuality, you know, maybe it's not. Maybe you have a little more trauma than you realized, and maybe the things you went through or that happened to you aren't normal. And you know, and so that's I think that's really important to recognize as well, that a lot of people don't even realize that they have trauma, and don't realize that maybe some characteristics that they have or symptoms that they have, you know, are a result of that. And if our staff were trained in that, they could recognize those signs before the person themselves even knows, right? And being able to help them accordingly. So
Yeah, and just even the treatment itself for those trained in trauma-informed care, I personally think could be improved. I think there's more fine-tuning that could be done on how to treat trauma. And so that would be, you know, just I guess, a general broadening of the skills needed, and maybe more in depth would be really helpful. So I would love to, you know, keep tabs on what you guys are, you know, keep the conversation going.
sure. Yeah. Absolutely. Yeah, and I think that's a good, because like I said, we talked about the mental health triage and the ED, but that's a very specific thing. And to make a more, we talked about trauma-informed care more generally across the entire system, not just in medical, but behavioral health as well. Because yeah, that needed its own month, and there's definitely been a lot of conversations about how to address that as well. Okay, so go ahead.
This is Katie with the Division of Vocational Rehabilitation. Just as far as I understand your identified issues, I just had a question about community resources, talking about workforce development. You know, I know in Moses Lake, for instance, the Division of Vocational Rehabilitation is a resource. We also have pre-employment transition services for youth that are, they may not be eligible for DVR, or they may not need to access DVR, but they may be in schools and have 504 and IEPs. And we do have providers that provide, and I meant to say they could be eligible for DVR, but they might not yet be accessing services if they have IEPs and 504. So excuse me. But again, they may not feel the need to access, but those services are available in various areas throughout the state. And then also community resources, or like foundational community supported employment programs, certified peer counselor trainings, and I believe there may be workforce development that is going on with connecting with the supported employment, the foundational community supports. So it might be good to access contacts through that program. And then lastly, I was just curious about the connection, the Washington State Department of Veterans Affairs, and was curious about connection with Puget Sound Veterans Affairs in terms of PTSD clinics and resources available. If you had any contact with the Puget Sound VA system.
I haven't.
Might be a resource is all I'm thinking. So those were just resources to throw out there.
Absolutely. No, thank you. I really appreciate that.
You're welcome.
Okay. Thank you all very much. That's wonderful.
Hello?
Input, comment. Yes. Go ahead. You had a question?
Yeah, I have a question, but it's not.
Go ahead. Yeah, sorry, you kind of faded out a little bit there.
Yeah, and I appreciate the work that you've done in reference to this PowerPoint you shared, but I just have a question. I really do appreciate the work with the veterans. Will that include those that are incarcerated, you know, such as in, you know, the prison systems or in jails? Will they be able to have access, or will you provide what you're moving forward? Will they be included in this?
That is a great thing to bring up. Great question. So the agency that is potentially going to be piloting this program for are you talking about the program with the Staff Sergeant Fox grant with WDVA?
I'm just
Yeah.
talking in general.
Okay. Well, yeah, and that's the main thing that we're kind of working on is that program with, you know, mental health specifically for veterans, and that agency who is taking on that programming actually already has a couple different programs, you know, in develop like that are already live and happening with the jails and with helping individuals with behavioral health struggles within the jails. And so I imagine that would be pretty simple and seamless to be able to you know, kind of include that focus in on that programming. I can't promise anything per se, but that I imagine, because that agency already has those connections and already has programming within the jails, that they'd be able to add, you know, offer that the veterans mental health services in that way as well.
But not in the prison systems. So I know that there's various veteran units within the various prisons across the state. So, because there's a
Yeah.
difference in jail and being in prison. So I guess if that's
Right.
something that they might be working towards or possibly work towards in the future.
Okay, I will bring that up with the work group. I appreciate that. Yeah, no, we are completely open to different ways to better approach serving veterans in all contexts, right? And so I think that's a great consideration, and I'll definitely bring that back to the work group. Thank you.
Thank you.
Okay, so I'm pretty close to being out of time as far as what I had on the agenda with everyone. I don't want to go over out of respect for the other agenda items, but I will be, you know, like I mentioned, Rochelle is going to be coming to the BHAB later this month to present on the BHAC and talk about, I'm meeting Monday with our board, and I'm going to speak with them about different ways that we can collaborate, what sort of things we could talk about at the end of the month at that meeting with Rochelle and with all the board members and those in attendance to talk about what collaboration might look like. And so Rochelle can then bring that back to the BHAC. And yeah, if you guys are going to have, like I said, I already shared this slide out. It was on these slides out. It was on the meeting invite. If any of these questions, if you have any thoughts on any of these questions or any of these identified issues, please do reach out to me. Would love anything that's going on at the state level to address any of these issues that the BHAC is doing, or that any of you know throughout the state that's going on that has been successful, or if anyone we could loop in or chat with to get some insight on how these issues are being addressed elsewhere. That would be so helpful. Yeah, I think that's about all I had for you guys. I know I'm at time here, so I want to thank you all so much for this opportunity to come and share about the things going on in our region through our BHAB, and I look forward to collaborating in the future.
Thank you so much, Brian. Appreciate it.
Absolutely.
Well, it looks like we're just right up close to our break happening at 10:50. So it looks like we're going to have 5 extra minutes in our break. So we'll go ahead and take a short break. And if everyone wants to come back at 11, we will have our director's dialogue. Thanks, everybody. Okay, everybody, we are going to welcome ourselves back. Hope y'all had a good break. We are going to be hearing from our leadership within the Division of Behavioral Health and Recovery. So I'm going to go ahead and turn it over to them.
And now, hey, happy September 6th, everybody. It was my husband's birthday yesterday and he was 50. So, right, I don't know why I'm announcing that to you all, except for he's not here, but I wanted to rub it in that he'll always be older than me. You know what I mean? I don't know. So anyway, no, it was a nice celebratory thing. And I told our team this a little bit ago, and I can't find it. I always see cool things on the internet, and then I can't find them when I want to. But I bring that up. Yesterday was his birthday, a great day for him. But one of the things I said to our team, and I just wanted to share this with all of you, and BHAC is, you do really hard work for us, and we thank you for that. And sometimes it probably feels like we are kind of ships passing the night, or like we're not on the same page, or even like it's just not your day in BHAC. And so I wanted to tell you this and what I told our team, which is there's somebody out there today who is having the best day of their life today. There's somebody out there today who got their dream job today. There's somebody out there today who is getting what they wanted. If today is not your day, tomorrow will be, or the day after that. Please keep up all of the hard work. We are changing our relationship and the dynamics, I think, together. And so tomorrow collectively is our day. I just wanted to let you know that. But thank you for that. Couple things that we're going to share with you. The biennial block grant application, well, it's submitted. Woo-hoo! So you all have participated in this, and if you want to virtually, or if you're in here right now, give yourselves a pat on the back for the work and the recommendations and the feedback you gave us. It made our product better, and by 2 days before the deadline, Janet and team submitted it. We're just super excited. And the feedback that we got this time around about the feedback that we gave you about your feedback, thank you, right? That's what we love to hear. It's this kind of like cyclical ability for us to communicate. So just, honestly, we're all feeling it. We hope you're all feeling it, that there is this, I hate this word, but kind of like synergy, right, that's happening around our relationship. So yay, thank you. The only other thing I wanted to share before I go and get a cup of coffee and Michael and Tisha do a little bit of talking is we've been really busy meeting with either being at conferences or talking with folks on a national level. And so I assume that person might be coming down saying like, why did they give this woman a microphone when she's shouting anyway? So sorry, I'm being too loud. But so we've just been busy, right? So I'm going to talk about a couple different things. The state tribal opioid and fentanyl summit was in May, and that was held and sponsored and supported by the Lummi Nation. We're really excited about that. It was the first state tribal opioid and fentanyl summit that we had in Washington State. And so we're just really, really excited about that. It brought together a lot of partners around the state to have those crucial conversations of what we in Washington specifically can do, primarily because it was a tribal sponsored summit, around the kind of disproportionate impacts that fentanyl and opiates are having on tribal communities in Washington State. Lots of commitments were made. It was a little bit, if folks have ever been to or watched on TV, things like the Centennial Accord or times when tribes are able to get together with the governor proper. It was like that. So tribes had an opportunity to talk about the things that they really wanted and needed, and the governor responded back. And so it was a good opportunity, I think, for us to just really, really reinvigorate our commitment to all folks who live in Washington. But when we know that disproportionately folks are being impacted, we have to answer that call, right? We know that there are folks who are disproportionately impacted who go into our criminal legal system, and we have to address that. So this is just one of those things where we had a really, really good opportunity to sit down and talk with tribes specific to Washington State. We also had our national tribal opioid summit, which was in Washington State again. And that was hosted and sponsored by the Tulalip tribes and the Northwest Portland Area Indian Health Board. Had to look that, read that right, because I didn't want to get it wrong. And that was just late August, the 22nd through the 24th. And that was a really cool opportunity. Many federal partners, many state leaders. There were representatives from Alaska and other states throughout the United States that came to Washington to have conversations about what could be done at the federal and national level to, again, address the disproportionality of the impacts of fentanyl and opioids on our tribal partners. Really, really great opportunity. And we had some kind of just cool, you know, when you go to a conference or you go to an opportunity or a learning event and they've got folks sitting out and they're like, take my card, or here's this information about the stuff that I do. At this last one, there were a lot of really good vendors that we are going to engage in conversations with to find out how we can continue to get creative. We already have vending machines in Washington State, but there's a company, several companies out there that take those vending machines and kind of make them do a little bit more, like help to identify where a shelter might be or where a place that somebody could find food might be, right? Or a place where somebody might be able to find a treatment program or self-refer to an ENT. So there are now technological opportunities that we are kind of exploring and figuring out what can we bring to Washington State. And then the last thing I will say is, as we were at the, unless it's later on in my talking points, am I talking about 988 and meeting with SAMHSA later? Okay, perfect. So then I'll give you all a little clue. Michael and I and Tisha, we let her go on vacation, otherwise she would have been there with us. But we had the opportunity when we were at the National Tribal Opioid Summit. The Assistant Secretary from SAMHSA, you all know SAMHSA, Miriam Delphine Rittman, is the Assistant Secretary from SAMHSA. We had an opportunity to meet with her in person. And it was myself and Michael and Michelle Roberts from Department of Health. Tisha was there in spirit. We just did a lot of talking about the rollout of 988 team and how that's going in Washington State. Washington State proper has donated and put more general fund state money or block grant money toward 988 efforts than SAMHSA has given to states for the efforts of 988. We're not the only state that's in that situation, but what it kind of created was an opportunity for us to have a conversation with SAMHSA about, we're in a different place than states that maybe don't have a lot of money being kicked toward 988 or don't have 3 different call centers right now that are taking 988 calls, or don't have a really robust opportunity to put together a plan for technological and operations that will kind of connect the 988 calls to our regional crisis lines. And we don't have all of that figured out yet, but we are absolutely leaps and bounds ahead of many, many other states in not only the commitment, but the vision around creating a robust crisis system for all Washingtonians. So I just want to let you know that that's something to be very proud of. That's something to be very proud of for the state. And I think that we owe a lot of, again, thanks to all of you for the work that you do in this group, but also the advocacy and the support that you all provide in other ways for behavioral health. I'm going to stop because I know that Rochelle wants to say something.
Yes, I just had to say that For those of you that don't know, I mentioned that I had taken a job with Washington State Community Connectors in May. My role is as a grant project manager with the Mobile Response Stabilization Service rollout, which is part of 988 and the System of Care grant. And so I've had a front row seat to see those efforts. I got to go to the System of Care conference in Baltimore about a month ago. And I just want to say, to tag on to what Carrie was saying, I also, as a community member, coming into this with lived experience and not as a professional provider lens, something else, I agree with her sentiments that we are leading the pack in terms of in the nation. Many states are consulting Washington for what we're doing right. For me, that was a really big encouragement because we can all sit around and gripe about things we notice are wrong. And we all know that there are still things we can be working on, but to have that balcony perspective to see all the things that we're doing right is really beautiful. And when I went to the System of Care conference in Baltimore, myself and my counterparts that traveled with me, we were pretty much the only state that had family representation, like the kids out without the parents, so to speak, in terms of we weren't with a state organization. We were a family org that showed up to a national conference where we were representing Family Voice. And I think that in and of itself speaks volumes of something else that we're doing right in our state and how we are incorporating people with lived experience and helping. We have gotten to a place where that has been a vision for a while, and we are starting to see fruit from that vision. And so I'm just really encouraged and wanted to share that.
Thank you, Rochelle. We didn't even pay you to say that. Exactly. I appreciate it though. And what a cool opportunity. What a cool opportunity. I love that. And I think it's really, I like the fact that Washington was able to send and stay out of the way. So thank you. All right. Michael.
Thank you, Carrie. And thank you, BHAC, for having us again today. And welcome or hello to those virtually. It's a little hard sometimes to forget you're up there. So good afternoon or good morning to all of you. I'm stumbling around here a lot because we have a lot to share and I know our time is fairly short, but what we wanted to do today is give you a snapshot this morning about a lot of the gatherings that have happened. You know, we're post-pandemic now for the most part, and we are gathering again. And so we're going to cover a few of these as Carrie started out. In part, to give you a sense of the breadth of them, but also for future reference in case any of you want to attend them or come to them. So we wanted to give you a little snapshot that way too. I will add on to Carrie's piece on the State Opioid Summit that the LUMI hosted. The governor was there, as was his health cabinet. So you had the leaders from DCYF and DOH and HCA and so on and so forth were all there to hear the recommendations of the tribe. So that was good. I'm going to stay on the theme of opioids for a moment to say that in July, about 300 people gathered down in Vancouver for the Region 10 Opiate Summit. It was Alaska, Idaho, Washington, and Oregon. And we had one day of sort of state staff across the 4 states and the tribes and Region 10 staff talk about the different strategies we're trying to deploy related to opioids. And then we had a couple days of presentations, and the 3 highlighted presentations or keynotes. One was on the Good Behavior Game, which is a prevention strategy, and White Swan out of Washington State presented. And they had young people who had gone through this program since like grade 4 or 5, and now they're graduating from high school, they've graduated from college, and they just really attribute a lot of their success to the prevention services they received in school. And this was an area very challenged with suicide and a lot of drug use in the past. So that was good to hear. There was also a harm reduction out of Portland that presented the work that they're doing with harm reduction strategies. And then there was a treatment program in southern Idaho, a residential program that really talked about engaging the patients, if you will, or the individuals they were serving, not only in residential, but then staying with them for 6 months, a year, 2 years afterward, having routine checkups and making sure that all those things were continuing to happen in their lives. So it was, they were all good keynotes and presentations. So that was the Region 10 Opiate Summit. It happens every year, or has happened the last several years. We also have the Coalition Leadership Institute. This is a prevention coalitions around the state gathered. This happened in August, and about 180 people showed up for that, really to learn not only from our staff doing some presentations, but also to learn from one another across the different coalitions in the state. And right now we have about 100 of them, or 110 or so, that are working across the state. We had the adult in the adult SUD arena, we had the Transforming Our Communities Conference. This happened in June. You're all laughing at me.
I'm like, I gotta teach more.
I'm talking too long or too long? Oh, I'm turning my head, turning the microphone with the, see, you know what I mean. It's okay, I'll keep the microphone with my head. Susan, can you hear me okay? All right, we're good. Okay, all right. I got to take performance classes or something here. So we have the, anyway, there was a Transforming Our Communities event that happened in June. Between 350 and 500 people showed up for that at any one time. And this was a 2-day event aiming to bring diverse participants together to understand the perspectives of people who use drugs and understand the importance of equitable access to care for services, build partnerships, and connect with people in their communities. So not all of, we're getting better in terms of not only those that have lived experience and are in recovery, but also including voices that are currently using and their perspectives of how they would like to see services made available. So that was a good event for them. And now I'm going to turn this over to Tisha, and she's going to talk about a few more of our events this last few months.
Hey, good morning, everyone. Tisha Kirschbaum, Deputy Director over Treatment and Recovery Programs at DBHR. It's always great to see everyone again, and I especially want to make sure say hello to the folks on who are joining us virtually. I'm looking at the screen, so hello. So just a quick show of hands, anyone here able to join us in person at the Peer Pathways Conference that happened last week? Wonderful, wonderful. Not to pick favorites, but I'm going to pick favorites. This is my favorite conference. It's just a really, really powerful event. So we hold it every year, and it really is kind of the professional development opportunity for peer counselors across the state. The past few years, because of COVID, we had to do it virtually. So this is the first time we were able to come back in person. And I believe over 400 people were there. So it was pretty exciting. And what I've heard from folks is it was a really great kind of powerful event. So hopefully, if you were able to attend, it was a good experience for you and you walked away kind of feeling revived and refreshed. We've also, like Micah was saying, this is definitely kind of, we're kind of wrapping up our end of our conference seasons. So we've had a couple of other conferences that we've also sponsored or organized. The next one is connected to our New Journeys program, which is also our first episode psychosis program. And this one was a virtual gathering. It was very much technical assistance and kind of a learning collaboration for the different programs and providers that are involved in New Journeys to kind of come together, learn from each other, figure out best practices, get revived, refreshed, those types of things. If you guys have ever, I'm sure you've all heard of, or many of you have heard of, and if you haven't heard of Dr. Pat Deegan, please check out Pat Deegan. She is an amazing woman. She is a person with lived experience. She is also has her, gosh, I should know this. If she's a psychologist or psychiatrist, I can't remember exactly, but she is just extremely powerful because she comes from that lens of I am a person who has spent time in an inpatient mental health setting, and I have also gone through and got my doctorate, and now I am providing services. And she does this amazing training to help us all remember kind of where our focus should always be. So she was one of the keynote speakers. We also had our WISE symposium. So that happened in August. This was also a 2-day virtual event. It's interesting. My head kind of goes to, we don't have to do virtual events anymore, but it's fascinating coming out of COVID and some of the restrictions that some of the things that we learned are there are some values in doing some things virtually because there's a way for people who maybe wouldn't be able to go to an in-person event that you can also participate. So we're in a really interesting place in the moment of kind of like, do we stay virtual? Do we do a hybrid? Do we try to do things in person again? So it's just kind of an interesting space to be kind of figuring all of that out. So hopefully many of you have been able to come to our WISE symposium over the years. This year it was a 2-day virtual event for WISE providers to network, learn, collaborate, make connections, and just kind of renew their passion and energy for WISE. So there was approximately 700 people that were registered for this event. I believe it was kind of, we did lots of keynote speakers and just I wasn't able to attend this one, but I also heard really exciting things that came from this event. I think those are the things I'm going to talk about at the moment. Oh, and Michael, you might be bringing this up in the future, but also I haven't looked forward to my talking points. But another event that we have coming up is our co-occurring conference that's going to be coming up in October. So looking forward to that event also. I don't know.
We have the co-occurring conference left, and then we also have the prevention summit that comes up in October as well. So did Janet have the dates there?
So Kim, would you be willing to get that information to Nathan so he can get it out to the whole council? Perfect. Thanks, guys.
Back to me real quick. I am not going to take a ton of time on this unless Kim and Nathan, you correct me. The phases that are in my talking points, I assume we're going to flesh out when, and the council helps to dictate all of those things. But okay, so here's something, team. We had our monitoring visit with SAMHSA in June, and I'm not sure if folks remember that. That was an entire HCA effort. I think that the team that put that together, 3 folks right here that helped put that together, engaged with every division and area of healthcare authority to kind of flesh out a lot of the work that we're doing as we talk not only about just the mental health SAMHSA block grant and the substance use or the SEPTERS, whatever it is now, block grant, substance use block grant, but also how that fits into integration, right? Because we moved over 5 years ago, into healthcare authority for full integration. But what that's caused a little bit is a little extra level in a relationship that we in DBHR have with you all as BHAC, right? We're listening to the feedback that you share with us about how to review the applications that we have and offer feedback. And some of those concerns we floated up as part of the SAMHSA visit that we had. And so as part of the checkout that we had, one, I'm going to brag for a second. The person that we had from SAMHSA said he was super impressed with the Washington State folks. It was one of the most enjoyable visits that he had had. And again, we're looking at these 3 leaders right here that were really instrumental in making that happen. He was in a welcoming environment, but also really felt, I think, talking with the council, getting an idea that we wanted to be transparent and wanted to make this work really, really was, I think, meaningful to him. And he said, hey, there's TA you can apply for. There's all of these things. And we kind of already knew about it, but he was really helpful in having us, I think, pinpoint some of the things that we wanted to make sure got in the application. So the team submitted that application, as all of you know, right? And so we did request TA support from SAMHSA for the council and for our partnership together. And we received confirmation last week that we have approval for that TA, as well as kind of just proposed timelines for implementing training. And so Kim and Nathan, I think, are probably the leads for walking that through, sensitizing that with all of you, getting it acclimated and getting us up and moving on that. So it's really exciting. But I think that the phases kind of once, you know, we're looking at starting now and it'll extend through January of 2024, I think, right? So short, quick, but meaningful TA, I think that we're going to have an opportunity to do. And I know that there's some intended outcomes that together folks will work on, but you know, it's really about how can we establish common knowledge, right, between the mental health block grants, the history of it, the state use of it, how we propose using it, how the legislature proposes using it, how you all review it and give us that feedback, and how we can have you all, not just how typically councils participate in the process, but how we can kind of decide together the way that we want to do it for Washington State. So we're just really excited about that. And be looking for more conversations, I think, with Kim and Nathan about what that time frame. Before I move on to a True Blood update, does anybody have any questions on that TA piece? Kim?
I wanted to add just two like colorful highlights to that. One is that as we went to SAMHSA with the application, they were really excited about it and the application across other states and how that would benefit kind of our work across like nationally with councils. And then in other endeavors, we've had meetings with some other states from learning collaboratives we've been in, and they're also interested in connecting state councils. So there might be opportunities in the future for us to expand the TA with SAMHSA to other areas we identify as we begin work, and then also meet with other states.
So I think I'm like probably, along with Vanessa, one of the most longest. Oh, I'm Carolyn Cox, by the way. That's who's talking. I think I'm one of the longest standing members of this council. And I'm going to tell you, this is wonderful news to hear because I don't know how long I've been really wanting some meaningful partnership and have been talking about it for quite a few years. But it's so nice to see that this is coming together. And so thank you guys for continuing to push for that partnership. So I'm just super excited about this.
It really is all of the teams talking, right? We are one big team as we do this work together, and we've got the same goal. We may get there in a different way, but we are all one team. And I think that that's kind of the cool thing about this too, is that we want to do a refresh. Things have changed, COVID happened. We all get an opportunity to say, what do we want this council to be? So I'm excited too. Who wants to talk about True Blood?
Worst thing about it.
I was trying to make it lighthearted for you, Tika.
So, not to assume that everyone is fully aware of what True Blood is. So just real quick, I think at the last meeting, I believe that Nicole Mims from DBHR and Tom Kinlan from DSHS Office of Forensic Mental Health Services came and gave an overview of kind of True Blood, everything to do about it. Since then, you might have noticed in the news that some more stuff has happened when it comes to True Blood. So one of the things that has just, and if you guys already know this, I can talk about other stuff, but I'll just give a quick overview. So, the state got sued. We lost. From that, and that happened way back in, I think, 2014, 2016, something like that. From that, there was a settlement that basically it said, if you agree to do these things in this settlement, basically we will not collect the fines that are accruing. Well, this past fall, the plaintiff said, hey, we think that maybe you're in breach of the settlement. And so then we ended up having to go back to the court. And we've recently, just in the beginning of July, got the judgment from the court, from the judgment from the judge, who said, yes, state, I do think you're in breach of our settlement. And basically you're in breach because people are still, for a certain chunk of time, too many people were waiting for too long to get access to competency restoration services. So they were waiting in jail for too long of a time. So with that, there comes a whole flurry of different things that we need as a state to make sure that we are doing so that we are in line with what the court order says. A couple of weeks after we got that announcement, there are a multitude of different counties who have come together. How many out of how many? Do you remember? Thank you. So 20. So
22 and the count.
And so the Association of Counties and 22 out of our 39 counties have come together and said, hey, this kind of how things are happening right now with people not having access to get into the state hospital with that is really affecting us. And we think that kind of these how you're kind of doing things at the moment are actually not allowing us to, or it's undue hardship on us. So that just has also happened. Also, mostly in that particular lawsuit, DSH, a different, not the Healthcare Authority or the Division of Behavioral Health and Recovery was named. It was the Department of Social and Health Services that were named, but we all we're one state. We work hand in glove together. And so we are really looking at what is it that we can do to help strengthen and assist with getting people discharged from the state hospital and moved into community placements if they still are in need of treatment, or also saying, hey, as you're discharging from the state hospitals, what can we do to assist with peer services or housing services or employment services or wraparound supports like a PAC team? So really, how do we make sure that the people have the supports that they need to be successful after their stays at the state hospital? So that's a kind of a nutshell when it comes to True Blood at the moment. I think part of what you guys had also asked for us to give an update on is recently we've done some restructuring within the Division of Behavioral Health and Recovery, and we actually created a new section. And that section is really focused on our True Blood work and also some additional work that's connected with making sure that people are transitioned out of the state hospitals well. Nicole Mims, who came and spoke about the True Blood work, she has been, she's now the section manager over this newly created section, and she's just kind of really building it from the ground up at the moment. So we're excited to be able to have done some reorganization to really give this work, this very important work of our True Blood settlement funded programs, and also the work with helping people get out of the state hospitals and be successful, kind of give it more of a framework and an internal infrastructure so it continue to be successful.
I'm going to ask Tisha if does that section also include the diversion programs that are out of True Blood and or things that we may want to expand from True Blood?
Yes, absolutely. So anything connected to True Blood, really.
Post-court, pre-court, all of those things. When you I think about that, think of Nicole Mims's shop. Her shop. And I think you've heard us say, because Tisha came with us last year, we do just continue to expand and grow. And I think the last count, we are either second or third largest in Healthcare Authority now as far as size for FTE go. We've been pretty big for our budget for a long, long time. But I think this is just a commitment that the state of Washington continues to show for behavioral health, is giving resources so that we can start to, in this case, pull some things away that really needed some special attention because they started to grow. And in order to get in front of that, especially in folks who are involved in the criminal legal system, right? We wanted to get in front of that and really start to get more eyes on that. So we don't have to wait for another True Blood type lawsuit to start to get a little bit creative. So I would assume that Nicole is probably going to be doing quite a bit of work with Tessa from administrative offices of the courts as well. So there you go, new information and new partnerships, Tessa. Right.
Keisha, thank you, Carrie. Just following up real quickly on Carrie's piece there. FTE wise, we have grown considerably. And we're somewhere between, I think, 180 and 200 FTE. We're seeing that actually across the region in the country as more attention's put on full-time equivalent, or it's a staff person, a full-time staff person, 40 hours a week. So sometimes you'll hear us call it a half FTE or full FTE, and it's just half-time or full-time. Thank you, Rochelle. The other thing to know about DBHR is because of the recent investments and our growth spurt sort of being straight up, is some of the support services within the agency are challenged to keep up with our growth. And so our vacancy rate now is, I think as our council, you should know this, is around 17%, I think. So that's to say we have more people to bring on to try to lift up some of this new work. If you have family and friends who need jobs, come looking our way once we get them posted. But yes, but that posting is a little bit delayed. So we'll be hiring throughout the year, I guess is my real point there.
I think this is important to note. Yes, we do have a 17% vacancy rate, but that vacancy rate really is not because people are leaving us. It is because we have so many new FTEs and we tend to promote from within.
Oh, yeah. Yeah. We're not immune to that, but yes. Yeah. But good point, Tisha. Yeah, good point, Tisha, is that we still have positions, I guess, that we're creating and trying to get recruited for. So the next part we're going to talk about, and a couple things, Nathan, here on the fly. One, because of our growth, I think that sending out our org chart sort of before each of these meetings is probably helpful, because you'll, within a 2-month period, whether we're adding sections or, filling vacancies and so forth, it's good for you guys to know who's sitting where. And, so I think that would be helpful. Also, this next piece we're going to talk about, I think there's probably a briefing document for you, because we're going to talk about some grants, not the block grants that you're all involved with, but we have a number of other discretionary or formulary grants that come to us from SAMHSA primarily, but sometimes there are other federal agencies. So we're going to give you like taste tests. We're just going to go through fairly quickly and say, here's what they are. Here's a few lines on each of them. And if you want speed dating, yes. If you want to know more, let us know. So I'll kick it off with a couple of prevention grants. And one of them is called the Partnership for Success. We've had this since 2018. And essentially it helps fund our community coalitions, our community prevention wellness initiative coalitions in high-risk neighborhoods across the country or across the state. So we are hoping that this gets renewed. Right now we're in the 5th and final year. And hopefully by the end of September, we will find out that we have another 5 years. If not, some of the opiate settlement dollars will backfill parts of it, but we don't have the resources to backfill all of it. So hopefully we can keep those efforts going across the state. The next one is what we call the Strategic Prevention Framework. They all have great names, right? Strategic Prevention Framework for Prescription Drugs Grant. This is a second year of a 4-year grant, and essentially it includes prevention campaign messaging, evidence-based prevention education, prescriber education, and increased utilization of the prescription drug monitoring program over at the Department of Health. So those are the 4 components of that grant. It's about $384,000 a year, and the one previous I mentioned, Partnership for Success, is about $2.2 million per year. So those are a couple on the prevention area, and Tisha's going to give you a highlight of several within her area too.
So I always like, when I think about all of the different funding streams that support behavioral health, I think so just a quick primer. just, I think it's important to think of Medicaid. We often talk about Medicaid, and Medicaid really is like, so I don't know if this analogy works or not, but I've been working on it. So I'm going to practice with all of you. I'm workshopping this analogy. So I think of like Medicaid as almost like the skeleton when it comes like, so you think of like my body, I don't know, funding for behavioral health. So you've got Medicaid that's like the skeleton. It really is kind of the backbone, and it is our largest source of funding, and it's ongoing and it's stable. It's not going away, and it's kind of complicated. But it kind of just funds treatment services, it's just chugs along, which is extremely important. Then we also have our block grant, which is large and it's stable and it's steady and it also comes along. And you guys are super involved with that, and we need you all for that work. And then we also have, so maybe our block grant is like our arteries. Okay, so now I'm getting to our capillaries. I maybe am building this on the fly. Perhaps I should have workshopped this somewhere else first. But so like our capillaries are we have all of these other little grants that we continually apply for and we get, and we use them to build cool new things that often then build into support like our treatment system, the Medicaid funding. It gives us the funds that we need to do the cool stuff that helps Medicaid be successful, or kind of those traditionally funded services work. You still have all of these other things that you need more flexible funds with, and that's often where all of these little different grants come from. So they allow us to pilot new things, they allow us to try new things, they allow us to figure out what works, what doesn't work. So they're exciting, they're fun, and they also have a whole other set of work and administrative burden that comes along with them. But that's really kind of what we're trying to describe today, is what are all those other little grants. So thank you for letting me give that context. So Michael just talked about some of the grants that go through the prevention section. I'm going to talk about some of our current grants we have right now that are in our P through 25 or prenatal through 25 section. And the first two I'm going to mention are really connected to our mobile response and stabilization services, which is a type of mobile crisis response that's specifically geared to youth and family. So we have two grants right now. One is our System of Care grant that Rochelle mentioned earlier, and she's working as part of that grant. And that grant is really designed to support the rollout of this mobile response and stabilization services and kind of help us build this out. And this grant focuses initially on some counties in eastern Washington. Another grant that we have that's connected to mobile response and stabilization services is a Transformation Transfer Initiative grant. This was a small short-term grant that allowed the state to receive some technical assistance to help support the implementation of our mobile response and stabilization services. It also helped us develop an MRSS 101 training. Then we have a grant. What does that stand for? That is the Mobile Response and Stabilization Services. So it is the youth-specific best practices for mobile response. Then we have our Healthy Transitions Grant, which is really aimed at developing non-traditional access and engagement opportunities for youth and young adults ages 16 to 25 to help increase access to behavioral health services. So it's really about how do we have some flexible funds to help young people get engaged in services. Because I think we all know that, one, it can be hard to get into services, and two, most people just aren't going to go knock on the door of a behavioral health agency. You need to have we need engagement and sort of outreach types of services that go to the individual to help engage with them. Project Aware, this is interesting because it's really it's a grant from SAMHSA, so our federal partner, but it was obtained not by the Division of Behavioral Health and Recovery, but instead by the OSPI, for the Office of Superintendent of Public Instruction. But so we're working together. So OSPI got the grant, And then they partnered with us to then work with school districts to roll out this grant. So the goal of it is to build infrastructure and expand the capacity of the state and district partners, so district educational partners, around behavioral health. Here's a brand new one. So it's called Integrated Care Program for Children and Adolescents with Serious Emotional Disturbances and Co-occurring Physical Health Conditions. You betcha. Integrated Care Program for Children and Adolescents with Serious Emotional Disturbances and Co-occurring Physical Health Conditions. So it's really trying to target the kids that have really complex needs. So not just the serious emotional disorder, things that are going also on, but also some complex health conditions. Because as we know, that makes it even more challenging to find a provider because of medical clearance and just all sorts of stuff. Okay, Michael, I'm going to let you do this next part.
Right. So we have a couple in the adult substance use disorder area, and one is the RSAT, the Residential Substance Abuse Treatment for State Prisoners Program. Name there. The RSAT program provides evidence-based substance use disorder treatment to incarcerated individuals with co-occurring disorders, substance use disorders, and mental health disorders. The programs are encouraged to use the use of medication-assisted treatment and prepare participants for reintegration into the community by linking them with recovery aftercare services. It's currently in Island County Jail, Jefferson County Jail, and the Washington Correction Center for Women. It's about $564,000 a year. The next one is the Adult Drug Court and Veterans Treatment Court Discretionary Grant Program. The Washington State Opioid and Overdose Treatment Court Response Plan will focus on providing Washington treatment courts with the training and resources needed to improve adherence to the national best practices, standards, and address overdose risk among its populations. HCA is collaborating with the Center for Justice Innovation and the Administrative Office of the Courts to create a data-driven initiatives to include the development of the Washington Therapeutic Court Evaluation and Review assessment tool designed to assist treatment courts in reviewing their practices in accordance with best practice standards. Additionally, the Washington Therapeutic Courts training supports will be a website that hosts the assessment tools and will also have training calendars with links to resources, trainings, and community forums. This is about 560, no, I'm sorry, this does not have the amount on it. But Tessa, you've been working with our agency on this one for a couple years now, right? Okay. Yeah. Excellent. The fire time. Okay, so if you did not hear that, Kim was mentioning it's about $600,000 grant for the duration of the program. On any of these, oh, I'm sorry, go ahead, Tessa. Okay. Okay, thank you. Which is another point, I guess, is that on any of these grants, we'll send out more information, but if you want a more full presentation at a future meeting, we can certainly do that as well. So I believe I'm handing this back over to Tisha.
One of the things you guys are probably picking up on is there's just a lot of different stuff going on. And it's cool. And honestly, there's almost 200 people that work at the Division of Behavioral Health and Recovery, and we have many different funding streams and many different projects, and it's honestly fun for us to have to do this type of exercise that says, let's pull all of these together and then read about them because like we know about them and we approve them. And it's like, oh, this is a good reminder about the nitty gritty details that are happening with all of these different things. So this next grant that I'm going to talk about, it's called our PATH grant, Projects for Assistance and Transition from Homelessness. I actually know a little bit more about this one only because 5 years ago when I was hired to come over here to DBHR, I managed this grant program. So this particular one is all about homeless outreach and engagement. So it funds homeless outreach engagement teams that specifically do street outreach to find people who are living in places not meant for human habitation. So people who are living outside, people who are living in homeless encampments, people who are living on the streets, to try to engage and interact with them to form enough trust and a bond so that they would be interested and willing and feel supported enough to become engaged in services. One of the things that I think is really exciting about how we have structured our PATH program here in the state of Washington is that we are very committed to the individuals who are doing the outreach should be people who have been homeless themselves before. Their ability to just form engagement and do that assertive outreach has really, I think, been key to a lot of our success. So that is an ongoing grant that we have from SAMHSA. It's for just a little bit of more bureaucratic knowledge, if you'd like to know. This is one of our federal formula grants. So a formula grant means basically you're pretty much guaranteed to, each state is pretty much guaranteed to get it each year. You just got to go through the bureaucratic work of getting it, and you have to make sure you meet your numbers and do all that good stuff. Some of these other grants that we apply for are a bit more competitive. Like we really don't know if we're going to receive it or not. And it typically doesn't always last as long as like we know we're going to get these PATH dollars every year going forward into the future. They typically don't increase, which is hard because I think we all know that there's probably more of a need than what we have funding for, but they're steady and they're stable. Let's see. So one of the things that's been, and I mentioned this at the beginning, kind of talking about how grants allow us to try new things out, kind of build an infrastructure, and then we think, well, let's go, what else can we build from this? So one of the cool things that we did is we had kind of our homeless outreach engagement services that are primarily funded through this PATH grant. From that, we learned from our homeless outreach engagement teams, we're out there, we're interacting with people, and what we're discovering is that we're interacting with a lot of people who have a mental health condition, and we're able to serve them, but we're running into almost as many people whose primary diagnosis is a substance use or an opioid use disorder. And this particular grant doesn't allow those individuals to have the same access to services that if they had a mental health condition. So this is under Michael's leadership. We are able to apply for funds through our SOAR grants, or State Opioid Response, as many 5 or 6 years ago, to use some of those funds to add staff to our PATH team specifically so that when they interacted with individuals who had a substance use disorder, an opioid use disorder, we could also serve those individuals. From that, as we started building out the programs that we received money for because of the True Blood settlement, part of what we were supposed to do from there is also create some type of assertive outreach and engagement program. And again, we use the same kind of model to build what we call our forensic PATH program. Okay, I think I've gone through all of the current grants that we were supposed to talk about at the moment.
I'm glad you brought up SOAR because this is a taste of the menu, right? Yeah. These are some of the grants. We do have a state opiate response grant that brings in quite a bit of funding for opiate response and a few others that aren't on here today, but we'll get you the full list and just want to give a little appreciation of all the things.
And I think these are things that you're used to us talking about as far as the adult SUD, adult mental health, youth SUD, youth mental health kind of continuum. But just a couple different things as we go into just the last thing we wanted to talk with you about, which is agency request legislation, is the team has also applied for, though we weren't successful, we will continue to try to expand our reach into fleshing out our eating disorder services. And so that's something that we have committed to. And then also, many of you know that we applied for the CCBHC grant and Washington was not successful, and we still maintain. That stands for, yep. I've got to write it down. Certified Community Behavioral Health Centers or Clinic Centers. Certified Community Behavioral Health Centers is what we think. Which is why we always put things into acronyms, right? Because I'm like, I don't know what it means. But that is, I think, shorthand for folks. We do have 10 CCBHC sites in Washington State right now. The federal grant that we were going to apply for would help to provide additional money on the federal side of things. And part of what we maintain is that Washington State has really shown a commitment to the CCBHC model by giving money from the legislature for this purpose. And when we looked at a lot of the states that got the CCBHC grants, that level of commitment from the state isn't there. So we're going to go ahead and say double-edged sword for being progressive and having a legislature that really is supportive in that sometimes we are not as in need as some other states. And so we're going to go ahead and let them have this. It's clinic. It's clinic now, CCBHC clinic. And so I just wanted to kind of raise your awareness on those two things, that those are still efforts that we will, as DBHR, continue to lean in on, meaning we will need your help as a council to continue to help us realize what that looks like for folks who reside in Washington State who could really benefit from those services. So just a little sneak peek. And then the last thing that we wanted to share with you is because it is September, we are already and have been a couple months ago started talking about what next legislative session that starts in January is going to look like. Last time I was here, I think I brought it up, or maybe that was the second to the last time I was here, but Nathan did share with all of you a draft that we had of agency request legislation around the crisis worker liability protections, if you remember talking about that. We've since gotten a lot of feedback from stakeholders, from partners, and that is getting smithed and updated and worked through. And I think, Nathan, you were going to also share, or you already have, a one-pager on that legislation. Is that right? We're going to. Okay. Oh, perfect. So you don't have it yet, but when you do, that's what I'm talking about. And the one pager will really just walk you through kind of what it looks like, but this is a signal that our team recognized last legislative session that there were some protections that folks were offered that work in the crisis space or work in things that are like firehouse models, right? Like fire departments, EMS, are offered certain liability protections that our team noticed were not, they didn't expand to folks who were part of a mobile crisis response team or the MRSS teams. And so they crafted a piece of legislation to basically figure out how it is that a variety of individuals who are responding to an emergency situation would have really similar liability protections. And part of what we're thinking is it could and should extend to some of these new things that we're doing, like 23-hour facilities that were new from last legislative session, as we put crisis stabilization units or crisis relief centers online. We want to make sure that that is an acknowledgement that sometimes when folks are in a crisis situation, things may happen that are not, it's not the outcome that we wanted. right? And that means we want to make sure that staff and volunteers and peers who are working in that environment know that the state of Washington has their back to act in the best way possible in that situation. So it's really just, I think, an opportunity. I'm really thankful that the team brought it up, really, and said, hey, we're noticing that there's some discrepancies between general emergencies, right? I guess I'll say medical, physical health emergencies, and the protections that those who work in behavioral health emergencies get. So we're hopeful that that will continue to move forward. Tisha, is there anything you want to add on that?
Just a couple of more thoughts to add on to why we thought it was important to request this agency request legislation. Also, I think something that's important. Oh, Susan's got her hand up. You go first, Susan.
Oh, okay, sorry. I'm going back to the discretionary grants. I was wondering, with all the recommendations that we made for the federal block grant, many of them you could not do or couldn't address right now. Is there any chance that the discretionary grants might be an avenue to address those in the future?
I'm speaking without approval from Michael, Carey, and Tisha, but I would think that those recommendations were wonderful, and I know we've said a couple of times in the meeting how much we appreciated them, and something that we'd keep close as we look at our other grants and apply for new grants.
Okay, so that's a yes. Is that right?
I think, Susan, I'm going to add to this, Michael. I think that's why beyond the block grant, we like to hear the priorities of the council, because they could in fact work into future discretionary grants or decision packages or other partnerships with other agencies. But knowing what you're thinking on a routine basis helps in that regard. So I think it's a yes. And although there may not be something specific today, we can certainly go back to those and look for ideas as we put future grants together. So.
Okay.
Since we already backed up, I want to say something too. Go ahead, Susan. Did you have something else?
Oh, no, I just said thanks. I'm done.
Oh, okay. Carey, when you were talking about the CCBHC grant and the result of that and explaining, first of all, I want to say I super appreciate like the increased explanation in all of this, like your cute word picture with the skeleton and stuff. It's actually super helpful because I feel like I have sat in on a lot of these conversations over the last few years and not really understood, kind of like, well, okay, and just taking it in. But like, I really feel like in this conversation, I really do have a good understanding based on the way you all are describing things. So thank you for that. In addition, I just want to say, and I'm kind of shifting my hat to the side to be like half BHAC co-chair, half my new role working for WSCC. But something that I've observed is that part of the reason why my job with WSCC exists is that federal partners recognize that community members that don't wear agency hats can sometimes accomplish things that agency hat folks cannot. And so from that lens, I just want to say, part of what I'm hoping to accomplish with WSCC is to build a network of all of our community orgs that really works more in harmony with one another. And right now, I have relationships with many community organizations and families all across our state. And so I just want to say, when you have opportunities where federal partners need to hear how decisions like that one to turn away that money from our state because we're doing a good job at our state, decisions like that and how they impact our communities. When you need community members to come forward and say the things that need to be said to bring those points forward, please reach out so that we can help you with that piece.
Katie, you've got your hand up.
Yeah, this is Katie. Yeah, I just want to ask Tisha, as far as the discretionary grant and the family crisis, youth crisis mobile response, if I heard you correctly, it's focusing right now on Eastern Washington. Is that correct? Or is this statewide resource?
So this particular grant, the System of Care grant, is really focusing on Eastern Washington, but we are attempting to roll out. Hold on, I got to look at my notes. Oh, I'm sorry. It's Spokane and Pierce. There you go. I didn't look at my notes close enough.
The reason I mention that is it's being shared as a resource through out there, as though it's a resource in the western side. So I just wanted to be aware of that.
Yeah, absolutely, Katie. We do have mobile rapid response. I can't remember the team, but the kids-based MRSS teams across the state. Yep, we do. It's just this particular System of Care grant is pumping certain amounts of money into these particular sites.
Sounds great. Thank you.
You're welcome. What was I talking about before? Where was I? Oh, yeah. Okay. So back to the agency request legislation. I think everything Carrie said, and as a state, we are moving our system, our crisis response system, to really have like a no wrong door approach and to be more accepting of people when they're in crisis, to be able to go to like a crisis stabilization center or have a crisis stabilization center that would accept like law enforcement drop off. We need to have those be facilities that will accept anyone. In the past, often, how some of those providers and facilities would manage their risk level is they would do some like triaging of individuals when they came to them. So they might say, hey, we don't accept individuals who come from a police drop off, or we don't accept individuals who maybe can't pass our medical clearance. They need to instead go to an emergency. And so what we heard from some of our providers is that part of that is because of liability. We said, well, what is it that we can do to address it to reduce the risk that providers would have so that they would be more open to accepting anyone that comes into their door? Because really what we want to be able to see happen is that people get the care that they need in the easiest way possible without having to interact with law enforcement to be able to do that. So this was one of the ways that we identified. We think if we made this particular change to the law, that would assist with it. So it's just a strategy that we are trying.
I just wanted to add really quick, one of the really cool components, I have had to learn all things about System of Care and mobile response stabilization service. And something that is really exciting to me as a community member about that rollout and that the System of Care model is that in mobile response stabilization service, the provider does not determine the crisis. The person in crisis determines the crisis. And that, as a person with lived experience going through crisis, means everything, because a lot of system embedded traumas that families experience come through that place of, I'm reaching out for help and you're telling me that what I'm telling you isn't a legitimate crisis, when yes, it is. So as a community member, that's very exciting. I'm so excited to be a part of this work and just to be having a front row seat to seeing our state kind of lead the charge in something that has a lot of federal success behind it. There are many states that are further down the pathway than we are currently in this, that have had really amazing results. And at a granular level, when I say results, I mean the outcomes of families' lives. And so for me, that's very exciting that we are on that pathway and we're working towards that. And thank you guys.
So where are the sites that are doing this rollout? Is one of them in Wenatchee? Spokane and Pierce County. Okay. That would be really good to know. Yeah, well, I ask because I'd really like to bring you and Rochelle on some work that I'm doing up in Wenatchee with Catholic Community Services. They've actually contracted with us to really look at the roles of peers on all their teams. I'm super excited because I've not just worked in families and youth, but I've worked in older adults, in homes. And honestly, all the skills are transferable. So yeah, so we're going to get the opportunity they asked us to come up and really support their efforts in supporting their peers and also looking at what types of trainings that they want to continue and going on. And I wrote when I worked in an agency, I got the opportunity to oversee the peers in that agency and got to write a couple of trainings. And one of them was ethics and boundaries within family and youth peers. And so with many inputs from other national folks that I worked for, or not worked for, but collaborated with when I first started doing this work. And some of them are folks from SAMHSA and other folks from FREDLA. And don't ask me what that acronym is, but I think, do you guys still work with FREDLA? Yeah. Even we have acronyms on the family and youth side that are out there. But super excited so I'd like to collaborate with you on some of that work that we're going to be doing up in Wenatchee, since you're so close in Moses Lake. Yes, yes. And I'm super excited because we're also going to the national conference, the Federation of Families. So super excited about that.
So we actually are a little bit behind schedule. So I just want to let everybody off the hook to we do working lunches here too. So I don't want to cut short our DBHR leadership's time. What they have to say is I really want to hear what they have to say. And I also want people to get food in their bellies. So please feel free to move about the cabin freely, grab something to eat while they finish up. Let's have lunch and continue this conversation. So Carrie just said that they are done and ready for questions. So if anyone has questions or comments, please feel free to fire away.
This isn't a question, but just a comment, Rochelle, on the agenda. I just wanted to say that if the agenda is right, it has me talking about bylaws for 2 hours almost. And I just want to say we probably get it done in a half an hour.
All right. Thanks, Susan. Okay, so we're going to take a 10-minute break. So it's 12:15 right now. So we're going to take a 10-minute break and everybody can grab their food and whatnot. And then we'll come back and have questions for DBHR before we start into the next agenda item. See you guys at 12:25. Okay, guys, sorry, we're running a little behind again. Apologize. Feel free if anyone has questions for DBHR leadership, ask away.
Let me try. Will that happen again? Was that the first one of its kind?
She was asking about the summit with the Lummi tribe and if that was the first one and whether or not it will be happening again.
Yeah, that's a good question. We don't know. There's been, because it was tribally really led, we came alongside and did just that, the supportive piece. I know that it's something, and Michael was reminding me, it's something that they're interested in finding out how it can be done on an annual basis. I think we're all kind of committed to the fact that there's a need there. But we don't know yet, Vanessa. And so I think it's something for us to keep an eye on and something for us to continue to talk with tribes about and how we can be in a supportive partnership to see if this can be something that's annual. It was open to community. Folks could register that were not kind of certified tribal members. It kind of quote unquote sold out really quickly. But it was open to tribal partners, to non-tribal partners. And it was huge. I mean, it was really cool. But the voices that were really there and the way that the particular Lummi summit kind of worked out is a lot of listening and getting feedback from tribes, helping to roll it into kind of a somewhat easy to understand document or list of recommendations that then the tribes were able to present to the governor. So while it was open to a lot of public members, it really was tribal centric to be supportive of getting all of our tribes in Washington State some voices. Yeah. Oh, we can get the agenda for you and ship it out. Yeah, just so that you can, absolutely. Yeah, Vanessa, yeah. I know. I love that because I think if you've met me, I may not remember. I'm just kidding. No, right? Thank you, Vanessa. Yeah.
There we go. The impact that opioids and fentanyl particularly are having on the tribal lands right now is so profound that there will be much more discussion between now and when another conference might happen. Like they are in contact, really direct contact with all the health agencies, with the governor's office, key legislators, federal government. Like they want action now, and they want us to move mountains now to get more services, more resources, so forth. So while these state and national conference sort of revved up the energy around it, I don't think that it'll be sitting very long. These conversations are continuing week after week and month after month now. So.
Does anybody else have any questions for DBHR leadership at this time? All right. Well, thank you guys so much. Really appreciate that presentation and for you spending this time with us. We're going to go ahead and move forward with Susan's discussion on our bylaws. Susan?
Thank you. So we really made a lot of changes to the bylaws. And so what you have in your meeting packet is a cleaned up version of the bylaws, as well as a summary of what the major changes are. So if anybody is, into detail, we're happy to share the marked up copy, but if you're not, I'm just going to talk about this and go through the changes and the cleaned up version. So probably one of the most important changes we've made, and Nathan, can you bring up the cleaned up copy on the screen by any chance? Great. And then if you, okay. Oh, where'd it go? Okay. And then could you, oh no, section 3. Okay, so one of the most important changes that we made is on this first page, and it is in section 3 under the name of purpose. And that is, we really changed the definition of our purpose, and that is item C in section 3. I'm just going to read you what we had there before. You can't see this, but the old description of services was, services shall be focused on recovery and resiliency by education on behavioral health issues, supported employment, and housing for adults, and or meaningful daily activities for older adults. And we looked at that and we thought, well, that's pretty scattered and leaving out a lot of stuff. So this new definition was something actually Josh put together for us, and then we played with it a little bit, but I'd really like any input on this if we're missing anything, and I'll just read it out loud again. Services shall be focused on recovery and resiliency by embracing trauma-informed, person-centered, and holistic approaches that support an individual's right to live a self-directed life through the provision of comprehensive treatment and basic social determinants of health needs, including community-based social emotional support, benefits, employment, and housing security services. And I just realized reading that is a really long sentence, but I would really love anybody's input if they, does this look okay? Are we missing anything? Okay, well, I'm not hearing any nays, so that's a good sign. Okay, so to me, that was the most important change, really, because our purpose, of course, is critical, that we're all in agreement on what our purpose is. So the next change was, we did just a minor one, and that's in Article 3, and it's under appointment of members, new members. We used to have like a 4-level approval level, which was approval process, which was very cumbersome. So we modified that down to a 3-level approval process. And what that is the membership committee will make a recommendation for a new member to the full council. Then the full council will make its decision and forward that on to the DBHR director. And everybody jump in and feel free to stop me if you have any questions. Okay, the next one is kind of important, depending who you are. We were talking about the fact that we used to have 3 excused absences allowed a year, and that's 50% of our meetings. And so we thought we would like to, and when I say we, I mean Crystal and I were the ones that worked on this, would like to bring up the idea of maybe having 2 unexcused absences be the limit for every year. and versus 3. Is there any concerns about that? Do people, any comments? Okay. And then the other section that I mentioned this to DBHR leadership when we spoke last as part of the executive committee, and this is for state agency members. Right now, their attendance, they aren't held to like a limit of upper limit of absences. And so what we're proposing is we hold them to the same attendance standards as the rest of the members, but give them the ability to, if they cannot attend personally, that they can have a proxy or somebody stand in for them. And we've done this just because there had been some times when people from state agency members just didn't have great attendance, and we really need their input. We really need their participation. Is there any problems with that one? Okay. So I'm going to move on to Article 4, Section 1, and these are kind of minor cleanup things. Nathan, the way we define the secretary position of the executive committee really are all duties that Nathan currently performs. And so we're proposing to get rid of the title secretary as part of the executive committee and rename that 5th person member at large. And right now, that member at large, really about the only thing that they're responsible, unique to the other members of the executive committee, is to oversee elections of officers. And I'll get to that in a minute. But so we would have chairs, co-chairs, and a member at large would be the makeup of executive committee. Okay.
Hello. Hi, Susan. It's
Yeah.
Kim. I'm terrible with the microphone. I'm sorry. I had a quick question about the secretary role, and I no problems with the member at large, but wondering if BHAC should also add to that role like action items for the council or action item follow-up, so that there's a member of the council doing that kind of alongside and walking with Nathan to ensure like the council is tracking action items and DBHR is tracking action items.
That's a great question, because that is typically a secretary type responsibility. The reason why, and I'm certainly open to change, the reason why we didn't have that in there is that at the end of each meeting and in the meeting agenda, we do track action items. But I'm open to having that be a member at large responsibility if the council thinks that that's would be appropriate. What does the council say?
So just as a reminder, we do not have quorum, so we probably will have to send this information out to the larger council by email to make sure that we get equitable feedback on all of this, Susan.
Oh, okay. Good to know.
This is Katie. I was just going to note that we have talked about action items in the agenda also with the when we meet with leadership and plan for the next meeting. So I don't know. I mean, that makes sense to me that the person could be also tracking that, serving in that role now. I think that it would enhance that we're making sure that those action items that are being proposed for next meeting, our next council meeting, are that we have an update, right, on how that's going in terms of connecting with the speakers. And so that would be my comment.
Yeah, good point. Okay. Well, I mean, those are really good points, both Kim and Katie. So I'll go ahead and just add that into this draft and have the member at large be responsible for following up and status of action items. So good, thank you. Good ideas. Okay, back to the changes. In section 4, section 1, also the we just move things around. This is kind of hard to explain without looking at the marked up copy, but election of officers was in another section, even though this section was called elections and officers. So we just moved information, all the information about elections and officers into one section, and that's section 4. And then another minor thing, the old bylaws had a section on nominating committee, and it was referred to as a standing committee. We don't have a standing nominating committee anymore. We do it ad hoc. So we made changes to describe that being our process versus a standing committee. Okay, and then on to section 5. This was about remote attendance, and when I've been on the council for a while, so when we first put this together, there was a lot of concern. It was in those olden days where there was a lot of concern about voting remotely and stuff like that, and there was concern about that. It's a new world, especially after COVID, so we really revamped it and made it much more amenable to remote voting and remote attendance. So let's see, remote attendance and voting updated to acknowledge that remote attendance is necessary sometimes, but also remote voting is allowed, and voting for officers remotely is okay. And so that process was updated to embrace that. Okay, we're getting through this really fast. The last section was on member or committees. And let me get to that page. Oh, we just updated standing committees and ad hoc committees, the information there, made it more general and made it more applicable to what our current practices are. So yeah, not much more to say about that. And that's the changes. Any questions, comments, concerns? Like Rochelle said, this will have to go out via email to the full membership because we'll need to vote on approving this. So there might be more conversation, but anything else from you that are attending?
This is Rochelle, and I just wanted to take a brief moment to acknowledge the hard work of the group that did this, and specifically you, Susan. You've done a bunch of heavy lifting this year on our behalf, and I just want to acknowledge your hard work and thank you so much. And to the rest of you as well that helped with these bylaw changes, thank you. This is something we've been talking about for a long time, and so to be seeing it coming to fruition is exciting. Thank you, guys.
Oh, thank you. Yeah, this is the first major revisions we've done to bylaws since we started, so it was needed. Thank you, Rochelle. So I guess follow up on this is all, oh man, I just got a cramp in my leg. Ow. I'll follow up with Nathan, get this sent out via email. And then Rochelle, how should we vote on this? What would be the preference?
You asked me that right after I took a big bite of salad, so I'm like mouthful of lettuce right now. Do our bylaws allow for, do our current bylaws as they are allow us to vote remotely?
Yes.
Okay. So I would say if that is the case, then let's submit all of this information out to the general council with the explanation that we were not able to vote due to lack of quorum.
Oh, you cut out.
Sorry, the mic died. Anyway, let's send out an email to our full council, letting them know that we didn't have quorum today, and because of that, we're not able to vote. And then let's ask for a specified deadline to have voting submitted by, and then we'll just vote remotely. Anybody opposed to that? Does anybody have any thoughts on that?
Gonna introduce something I thought was already introduced, but Nathan went through and made some suggested edits that were needed that may have been captured by yours as well, Susan. But if possible, I think from DBHR's perspective, we'd love to do like an overview of both of those, because some technical edits and suggestions that we have could be incorporated. So if we do that remotely and send it out, or I'm not sure what that looks like, and maybe vote in November, just letting you know that we have that as well.
Now we did receive Nathan's recommended changes and incorporated them. Are you just saying there might be more, or you just want to be able to look at it more carefully and see?
So like I feel like a really good example that's recently come up is we've been working with our Office of Tribal Affairs in terms of tribal members joining, and obviously there's a lot of logistics and respecting tribes, and so we've been drafting language to go into the bylaws membership specifically for tribal members, and they'll probably reflect similar to how we have state represented seats on the council, but that's just a good example of, like, you know, something that we will probably make a recommendation to put into the bylaws. And then the only other big things that I had were I know that the executive committee talked about having maybe an annual mandatory meeting in person, or possibly changing the cadence of the meetings, but those were the big ones. But I'd be happy to send those to the bylaw committee, or we can, send it to the full council, and then we can see how that works.
Okay.
So with that additional information, I think it might be wise, especially since we have kicked around the idea of having an in-person meeting in November. I think it might be wise to go ahead and wait until we have those recommendations and then just put it to a vote at the November meeting, if that's okay with everyone.
Sure. I mean, I personally don't see a need in the bylaws to have mention a mandatory yearly meeting, or in-person meeting. The reason why we're doing it in November is purely because we are doing strategic planning, and it's not something we can do remotely. So I kind of see a required in-person meeting being on an as-needed basis.
Great.
Totally cool. That definitely works. I guess, Rochelle, the next question, so I will definitely, with DBHR, we'll review this and we'll send out recommendations for bylaws to the full council, and we'll add that as an agenda item in November. Maybe even have a draft of the bylaws with council input and all the work that the bylaw work group has done. And then maybe we can, so.
Okay. I apologize, Nathan. I thought that I had I thought I'd gotten your input, so there must have been a misunderstanding there. So I would have hoped to have it already incorporated. So sorry about that miscommunication.
Oh, no. Yeah, no problem. No problem. And the work that you and Crystal did, you guys did the heavy lifting for sure. It's mainly like I said, like I feel like that tribal one is a good like example of kind of technical things to consider to add to the bylaws and stuff like that.
Okay, sounds good.
Okay, does anyone else have any other things they would like to bring forward for the good of the order? Okay, well, I guess we will, Nathan? So, just as
I
a
had one.
point of information before we go, the November meeting is scheduled for November 1st, which is the day after Halloween. It was brought forward to ask, Nathan suggested that we find out from everybody, is everyone okay with doing it that day, or would you like to move that meeting to another day? I just want to point out, I will be in Chicago for the Federation of Families Conference, and it sounds like several others will be as well in November, so that we need to factor that in as well. No, it'll be the week after that, the next Wednesday after the 1st. So does having it on the 1st present any additional challenges for anybody who's here right now? Based on the fact that we would be wanting to have that meeting be in person due to strategic planning efforts at that time? Would having it on the 1st be a barrier to anyone here?
Well, I just want to say, if Rochelle, you cannot attend, and there might be some other members that cannot attend on the 1st.
No, I can attend on the 1st. I'm going to be in Chicago the following Wednesday. So I just wanted to say, if we're going to move it, we can't move it to that Wednesday.
Okay, got it.
So Janet just suggested maybe moving it, rather than moving it to a different Wednesday, seeing about moving it maybe to that Thursday, so that if folks had to travel the night before, it wouldn't take away from what they do with their kids for Halloween. I'm in favor of that because I have a gazillion children and I have to come very far. So I really like that idea. Is anybody opposed to meeting on Thursday the 2nd as opposed to meeting on the 1st? As a reminder, this is not an official vote. We do not have quorum, but this is a temperature gauge of people's thoughts. So, okay. I think I think that we should send a message to the whole council asking if anyone's opposed to meeting on the 2nd.
This is Nathan. I have one more plug. We are wrapping up our annual block grant peer review that is conducted every year. And so part of that is, and shout out to Susan, who is such an integral part of our council, who's done lots of work in the past, but we form a work group, our BHAC forms a work group to compile a report of all the reports that I have compiled. So we will be sending out an ask for members to join that. And it's basically, to kind of give a very brief overview, there are basically facilities selected that receive block grant funds, and peers that then go and review those facilities. And then they are able to identify trends that are happening throughout the state. And then what BHAC does with their work group is compile a report identifying those trends, gaps in service, and other things, and then compiles and reports that to DBHR. So if that sounds like something you're interested in doing, I will be sending out an email asking for members to volunteer.
And Nathan and Susan and Rochelle, while we're on the subject of volunteer of members, do we have a current count of membership committee beyond? Do we have room to grow the membership committee?
Yes, we do. So if anyone is interested in joining the membership committee, there's, I think, off the top of my head, I think there's 3.
Vanessa and I have been filling in with that.
I think that's going to be a great opportunity during our strategic planning session to talk about that. I know in our last strategic planning session a couple of years ago, we did talk a lot about committees and subcommittees and get folks to sign up at that time. So I feel like we have an opportunity in the November meeting to really get more folks invested in our committees and
Right.
subcommittees.
And one question on that on that subject. Do we have anywhere, I apologize if I missed it, in the bylaws that talks about when you join a committee, like a commitment or anything about committing to work in a subcommittee? Or maybe that's too prescriptive, but so we can maintain like some stable participation?
There's nothing in the bylaws, Katie. That's a really good question. But we do have our meeting norms document, that we give out at orientation. And in that, it does have some specific comments about, if you commit to do something, do it. So we might want to bring that document out more often and just maybe go through it with the council in that these are the norms and the expectations we have, if you're a member.
Right. That sounds great.
Okay.
It's Kim. Sorry, I'm just jumping in here all over the place. I know in conversations with other states, there are some states that require that you have members who volunteer for at least one committee, and there are things like that that could be considered. They don't have to be considered for this round of updates, but as we work with TA, that might be a question that we kind of ask in the best practices for engagement.
Yep.
That's wonderful to hear, Kim, because I'm aware of, other councils that you do commit to a period of time of being on a particular committee or you're.
Yeah, absolutely. Hey, Kim, was that something that you heard about that was embedded in bylaws, or was it just another type of requirement?
So in Nathan's research, it's in some of the other states' requirements and bylaws. And I think as we can get you more information on that. I think the meeting norms is a really key thing to bring up. And I'd like to really explore that with the council and our TA. Yeah, I'd be really excited to bring the meeting norms out more often. The engagement and maybe see that bring an increase in kind of, I don't know, engagement and conversations. Yeah.
Yeah.
It's Katie again. I believe it councils that it has been, like Kim saying, in some, so that's why I was bringing it up as a potential bylaw. But yeah, I like the idea about the norms or I'm sorry if I got the name wrong, but the other thing, the norms that we have and having that go over that every once in a while.
Yep, agree.
Hold on, Tessa has a comment.
I think it would be helpful if we regularly saw a list of the committees and who is on and active in those committees. And not just once a year, but maybe twice a year or every meeting. So people can see who's doing maybe all of the lifting. And not to call out anybody who's not, but just to give an idea to people like maybe I do want to be a part of this committee and maybe even a synopsis of what those committees have been working on so that people can jump in.
I love that idea because I think my emails get lost because it has my personal email and not my work email. So I miss these emails a lot of times. And there's times that I've missed meetings because I was like, ah, crap. And I didn't forward it to my work email. And so, and updating the stuff because I don't even see, I'm not even on the list. But anyways, yeah, that would be awesome if we could do some updates on making sure that our information's correct.
So Tori suggested off mic also that we were talking about how we already have roundtable discussions for individuals. So maybe incorporating roundtables for committees in every meeting so that we are getting those regular updates. And I think if nobody's opposed to it, I think it would be great to get updating individual information on our November agenda. And Tori suggested that if we get updates from committees, we can be putting those on HCA's website so that folks can be aware of what work we are in the middle of, and if they want to contribute, they can know what we're doing. I think that's a great idea.
Yeah, I agree. Let's put it on our SharePoint site. You know,
Good idea.
Yeah.
Yeah, quick plug for anyone and everyone. If you haven't already, go to the PHAC SharePoint and try to log in. I can see views, and there haven't been many, so I know. so please, that's a great resource. It's going to be a great resource going forward. I think we've had like 3 or 4 or 5 views, so we have more members than that. So if you have any issues logging in or having problems, please reach out to me. But going forward, I think that's going to be one of the most valuable resources on the council, because we can do committee work there, we can do work group work there, block grant recommendations. For those of you who don't know, one of the greatest things about SharePoint is that you can work on documents collaboratively, so you don't have emails that have, you know, everyone working on it individually and 7 different drafts of the same document. So yes, if you have not already, please reach out to me, and yeah, try to get on that BHAC SharePoint.
This is my authentic moment as a person who does not love technology. Ironic, because I have a degree in technical management. But can we just plan to do at some point in a meeting in the near future, a tutorial on SharePoint? Because I feel like if you leave it up to me to go do it, I'm not going to, and I'm being honest about that. So
if the council's okay, our meetings are already packed. I could do a tutorial outside of a BHAC meeting and just set up a training or a walkthrough. I'd be happy to do that, and we could just set a time and schedule it for members.
That'd be wonderful.
Yeah, and I was going to say, I think for sure we need to let the full council know what all is on it right now, and any plans to add stuff, so they just kind of know. I mean, like Tessa's comment about who's on what committees, I mean, that should be on SharePoint.
Tessa is asking if Nathan could record a tutorial. He says yes. Right. Anybody have anything else to go to the order? Seeing a lot of head shaking, so I will give us back our day. Thank you guys so much for coming, and the meeting is adjourned.
Thank you. Good seeing everyone.